they have a compromised myocardium. The heart, the structure, how it is made, the microscopic structure is, it lacks the contractile elements, and they have more of fibrous tissue. So they have disorganized fibers. There's more fibrosis. The beta 1 receptors, which actually help in contractibility of the heart, is less. On the other hand, they have a higher alpha receptors on the peripheral vasculature. So if you stimulate the beta receptor, the heart will beat stronger. If you stimulate the alpha receptors in the peripheries, in the vasculature, they will lead to increased vascular tone. So on one hand, they have less of beta 1 receptor, decreased contractibility. On other hand, they have more vascular tone. So not capable for the function. So they have disorganized mitochondria, the cardiac troponin system is not developed. The diastolic filling is not adequate, it's shorter, they have a longer systole. They also have something called transient adrenal insufficiency of prematurity, or they have lack of corticosteroids in the body. They have the adrenergic receptors are downregulated. So premature babies all through they have functions which are not adequate to compensate. And when they're in a state of shock, then they can rapidly, they can worsen. So you should be very, very cautious in premature babies to diagnose and treat, manage shock. Now, giving a brief background about the physiology of shock and the components which maintain the body perfusion in preterm and term neonates, how do we actually diagnose shock? There is no single gold standard till date which can tell you that this baby is in shock. Even though we have very fancy technologies, we have functional echo coming in, we have NIRS, we have cardiac MRI, we have electrical impedance, and so many things. But none of these anyone can stand as a gold standard. So you have to diagnose uh, in in a way that you include most of the things. You have to make the puzzle yourself. There's no one way to diagnose it, right? So it's very important that what is the clinical history? You cannot leave the clinical history. You have to make sure, because history will give you the clue about a patient who is in shock. So if there's a baby who had a history of chorioamnitis and now going into shock, you will think about septic shock. A baby who was feeding all right and there's abdominal distension and abdomen looks really red and angry, you will start to think about necrotizing enterocolitis. A baby who did not breathe well at birth, who had low pH and now manifesting with shock, you will think about cardiogenic shock because of mental asphyxia. A baby who was on a ventilator and suddenly you feel the baby has crashed down, and you think about dope, you think about tamponades. So history is very important. Look for history of blood loss similarly. So a clinical history will help you to clinch the diagnosis in many cases, and it will help your job become much easier. So don't lose this on your path. And then there are a lot of clinical parameters which can tell you about the poor cardiac output state or the blood flow. Some of them have been there since long time. And although the parameters, if you talk about individually, they may not have great, let's say, sensitivity, specificity, or predictive value, but in combination, they tend to lead you to the diagnosis and help you to pick up shock earlier. So one is the heart rate. We understand when there's a state of shock, the heart starts to compensate by beating faster to maintain the cardiac output. So that is a parameter which you should be looking into. If there's increase in the heart rate, there is tachycardia. But you also should understand that only heart rate can increase in various other conditions, including even pain, irritability, and so many things. So there could be heart rate variability. Then the capillary refill time is something which, as a clinician, you should pay importance to. People have seen the sensitivity and specificity of capillary refill time on various places, starting right from the sole to the thumb to body here and there. It is good to stick to the central part of the body, which is the sternum. That is the place where you should look for the capillary refill time. And based on whatever data we have, a capillary refill time of less than 3 seconds is okay for the perfusion. If it is 3 seconds or more, then it is said to be abnormal. And if you look at the sensitivity and specificity of capillary refill time per se, then it is not that great. or what people have done, they have compared all these parameters to superior vena cava flow. So there was a time in 2010s when this was given a lot of importance, and it was thought that the blood which is coming through the superior vena cava should be the gold standard. So you can measure the blood coming through the superior vena cava, and since it is carrying blood from the brain also, and it is not affected by any shunt in the body, like the PD or PFO, it was thought to be that blood coming from into the heart is the gold standard. And all these parameters have been compared with so-called superior vena cava flow seen in functional echo. So therefore, based on that, the CRT has a limited predictive value. Similarly, central to peripheral difference, if it is more than 3 degrees Celsius, if you are measuring the peripheral temperature, now most warmer have the probes to measure peripheral temperature. This is a very good, simple tool. If the periphery is getting cold, it can tell you that the peripheral perfusion probably is not good. So you make sure the baby is not cold. You look into other factors. Now, even that has not a very good predictive value. If you look at the area under curve, it's just 0.47, not that great. And it is seen only in 5-6% of preterm neonates who have episodes of hypotension, studied by Lambert et al. Similarly, decreased urine output. So when the urination starts to come down, it may tell you about shock, but during transition in the first 24-48 hours, the urine output might be low. Later on, because of tubular immaturity, the urine output might be high. In patients, despite diminished perfusion, collection, titration might be a problem in newborn babies. And although the correlation is significant with the SVC flow, the SVC flow of urine output, it doesn't have a great coefficient of determination. Blood pressure. Blood pressure is something which we are still obsessed about. I'm also not able to get out of the trap of blood pressure despite understanding various policies and everything. So it's controversial, and the data which we have from the 2010s is that it does not correlate or very weakly correlates with the organ perfusion. Uh, the cutoffs have been again controversial. What should be the cutoff? So the mean blood pressure less than the gestational age is some definition with some unit use. A mean blood pressure less than 30 millimeter of mercury is a cutoff which most neonatologists and hemodynamic experts they take, because below 30 millimeter of mercury, what happens is the autoregulation is lost. So that is the cutoff what is taken. So alone, they don't have a very good predictive value, hypertension. But if you combine the two, like the CRT and hypotension, the sensitivity increases to 80%. One usual thing which you should note down is the way you measure the blood pressure in the unit, the cuff size, those are really important. So look at the UK guidelines, how to measure the blood pressure if you're doing it non-invasively. If you're doing invasive blood pressure, which is thought to be the gold standard in shock, then you take care of the zeroing and bubbling and the height, all those kind of parameters. Now, since we are quite obsessed, and I told you that I'm really obsessed and fancied about blood pressure, not alone as a standalone tool, but yes, in combination with other markers of organ perfusion. So you should know what is a normal blood pressure for the gestation. And there are various papers which are published to look into the centiles of blood pressure, like 10th centile, 50th centile, 90th centile. And these are for various gestations also, these are available, and these are available for days of life also. So two papers, which if you have time, you can read, is one by Kent et al. And other by Polovic et al. So these are the papers which have published various charts and nomograms of blood pressure, depending on gestation, depending on day of life. So what we have done in our unit is we have made a chart, because graph may be sometimes difficult to read by everyone. And this is a chart which is there in our unit, and this is in the SOP, this is in all the rooms. So these are cutoffs of 10th centile, 90th centile amongst various gestations. So this is the 10th centile, this is the 90th centile in the bracket, and you have the median. So this is the normal blood pressure, which we tend to try to attain in these babies when they have shock. And again, these are as per the day of life, and these are also as per the gestation. So this chart is there in the unit. We don't have to look into individual studies and look into individual graph. So one chart says it all. And it is easier for the consultants, it is easier for the residents, it is easier for the nurses to understand what we are targeting as the blood pressure when you are treating shock. So this is something which we can replicate in your units. Then, apart from the usual thing which we talked about, the heart rate, the CRT, the blood pressure, urine output, central peripheral differences, one important thing which is helpful in clinical practice is blood gas. So if the blood lactates are increasing, if base deficit is more than 5, if lactate is more than 3, again, those could indicate that there is poor perfusion. Of course, lactate may also increase because of sepsis per se, because of metabolic disorders per se, because of decreased clearance of lactate per se by the kidney or increased production in the liver, so many causes. But in patients on whom perfusion is failing, if the serum lactate is increasing, then it's a good marker. So lactate of more than close to 6 has insensitivity of almost 100% and 85% of specificity to predict death and major brain injury. It has an excellent predictive value also with area under curve being 0.86. We also look at the clearance of lactate once you start to treat shock. And if the lactate may initially rise in shock, especially if you are using epinephrine, norepinephrine, these kind of drugs, and then it should start to clear. So if the lactate is not getting cleared in 8 hours, 12 hours, again, that is a bad prognostic marker when you're treating the patients. Now, most of us are using pulse oximetry, and we have Massimo technology, and it gives a term called PI, or the perfusion index. Okay, so this can be also measured. It is basically takes care of the ratio of the pulsatile and the non-pulsatile component, and there is a value which is given in your machine. The PI is this much. Okay, and usually the median PIs which have been seen in preterm term babies, it remains around 0.81 and so on. If the PI is decreasing, especially the trends, if you're seeing if the PI was okay one, now it is coming down. So a PI of less than 0.44, 0.55, it has a sensitivity of close to 90% and specificity of close to 90% with area on the curve close to 0.9. So PI is another thing which, since most of the units have started to use advanced pulse oximeter, this is seen in the bedside. So you can use the information of PI. Some of the advanced tests, again, this is available in our unit, and some of the tertiary units, they also use near infrared spectroscopy. They look into parameters like what is the regional oxygen saturation and what is the fractional tissue extraction. Based on that, also, you can look into the organ perfusion. And right now, there is limited data in newborn to use NIRS as a therapeutic intervention. So you are not going to chase it. Right now, the data is quite limited, and we do not have enough evidence to suggest this as a routine tool to manage shock. Then there are other indexes like pleth variability index, which look into the variability of PI. And of course, you can look into the beat-to-beat cardiac output with electrical cardiometry, where each beat cardiac output you can see. Then visible light spectroscopy, cardiac MRI. So these are all advanced tools which are available now. Even in our country, many of them are available. And those who are really kind of passionate about hemodynamics, some of they are studying these tools. But in clinical practice, if you can add clinical history, good clinical history, and you can add some of the clinical parameters, that would lead you to diagnose shock early. Now, imaging has come a long way in India in the last decade or so, and Dr. Amit is currently running a Sonic course now, which is there for, I think, almost 3 years, uh, which has trained, I think, more than like 200 odd neurologists. Present batch has 80 odd people right now training. So we can look into various direct causes of shock and imaging. So if you are doing a lung ultrasound, if you see an image there, I don't know whether you have idea about lung ultrasound. So this is an image of lung ultrasound where the lung sliding is absent. This is an image which shows something called lung point, and this will tell you there's a pneumothorax straight away in matter of seconds, and you know that this is causing shock. Next, you can see that you can diagnose. You just put a probe in the brain, and if you have something like this or you have something like this, both of this can cause shock. This is an image of vein of Galen malformation, a large AB malformation in the brain. This is an image of a huge intraventricular hemorrhage in a premature baby. So don't forget to scan the brain also when the people have shock if you're scanning. Now, this is another tamponade pericardial effusion here. If you just place the probe, you have little knowledge about echo, then also you can diagnose pericardial effusion. And if you are trained in functional echo, you can see whether a large duct is present in an extremely premature baby and whether it is causing problem. So it can help you various modalities, not only echo, but lung ultrasound, cranial ultrasound, functional echocardiography. All of this can help you at the bedside if you know how to use these tools. Even if you know the basics, you don't need to be very high advanced level echocardiographic. Now, I will talk on a few slides about echocardiography as I introduced to you because most of you can maybe refer to the video or YouTube because it's not possible to cover all of these. But you can, in the echo, you can assess when there is suspicion about structural heart disease. One thing which you should rule out in shock, especially in the first week of life, when you anticipate that if there was a duct which has closed and if there was a duct dependent circulation, the newborn will present with shock. The coarctation of aorta, hypoplastic left heart syndrome, interrupted aortic arch, all this can present with shock in a healthy term baby who was doing all right, suddenly in day 4, day 5, day 10, anytime. Similarly, systemic pulmonary circulation, which is duct dependent, can present with severe hypoxemia leading to shock. So, if you are if you have a pediatric cardiology backup, then you can rule out structural heart disease. But at least with the clinician, you should have the suspicion based on the history whether this is a possibility or not. Then, if you're trained in functional echo and you're sure that the heart is structurally normal, you can pinpoint which component, which we discussed in the first slide, which component you need to focus on to manage the patient, whether it is the volume or the preload, which is a problem. It is the contractibility, the way heart is pumping, the power heart is for pumping, which is the problem. Is it the cardiac output, which again depends on the contractibility and the afterload, which is the problem. Is it the left heart which is not pumping well? Is it the right heart which is at stress? Or what is the global myocardial function? And whether there are presence of some of the disorders in neonates like a large hemodynamically significant PDA in a premature baby, especially those who are less than 26 weeks, that is really causing a problem? Or is it a term baby who has a setting of pulmonary hypertension born through meconium or asphyxia or pneumonia, or even maybe idiopathic, who is now presenting with hypoxemia and shock, so leading to diagnosis of pulmonary hypertension? So all these can be diagnosed easily, and each of these 6, 7 major things which I have presented to you, this has more than 6, 7 components. Each one has 6, 7 components, and you can go through again, say the video in YouTube if you want to learn all this. But I will just introduce these to you very shortly for benefit of some of the students who are here. So one thing which can help you to understand the preload is, of course, how the heart looks like overall in echo, the impression. And the IVC indices has gained a lot of popularity over time. And there are many pediatricians who look into the IVC to understand how well the heart is feeling. So if an IVC is normally looking full to you, that means it is quite well filled. And normally what happens during inspiration, as blood is sucked inside the heart, the IVC will collapse. And during expiration, it will again go to its normal maximum dimension. So when the IVC is collapsing more, the collapsibility is more in a spontaneously breathing baby. So if it is more than 50%, then you can think about a hypovolemic state. But when you're giving positive pressure ventilation, these relation gets reversed because on ventilator with positive pressure ventilation, the IVC will distend during the inspiratory phase. So there are other indices like which can be used, like the distensibility index. There's an index called IVC variability index. All this measure the diameters of IVC, maximum minimum by maximum, maximum minimum by minimum, maximum minimum by mean, and so on. So all you have to do is measure the diameter of the IVC, the maximum and minimum. And from this, all these indices could be calculated. And you can look into the cutoffs, 50%, 18%, 28%, to understand whether the newborn is possibly hypovolemic or may respond to the fluid boluses. So it can help you to understand the fluid status of the baby. Although it has got some fallacies, of course, but this can be a help to you when you're managing shock and thinking about the preload status of the heart. Then there are ways to look at the cardiac output. You can actually measure how much of blood is pumped out of the left side, how much blood is pumped out of the right side, how much blood is coming back to the SVC. So these all could be measured. So I'm giving an example that if you want to measure the left ventricle output, so what we need is heart rate, parameter called VTI, a parameter called diameter. So diameter of aorta, if you can measure, and heart rate you can take from the ECG or from the pulse oximetry, then you're left with VTI. So VTI is the blood which is pumped out of the left ventricle in one stroke. So this can be measured in functional echocardiography by putting something which we call a pulse wave Doppler at the LVOT. And you get a trace like this. And if you have the VTI measurement, the heart rate, and the diameter, you can measure what is the amount of blood being pumped out from the ventricles, what blood is coming from the SVC. So all of these are based on a similar kind of principle. Then I personally give a lot of importance to eyeballing, that how you see the heart is pumping and how you see the heart is filled without measuring anything. And you can have a fair degree of eyeballing. If you have done 200, 300 echoes, you get a lot of idea about eyeballing. So if you look at these, I hope it doesn't stop. There's some problem with the videos with my laptop is overloaded. So if you look at this heart, so this is the left side, this is the right side, this is left atrium. Sorry. Yeah, this is left atrium, this is left ventricle, this is right ventricle, this is right atrium, this is the intraventricular septum, this is the intraatrial septum. So by looking at this heart only, look at the LV. So it is contracting well. It is contracting well. And this is the free wall of the LV. This is the ventricular wall of the LV, septal wall. Both of this are coming close to each other. If they're coming close to each other, roughly if you say that it's coming close, traveling a distance of at least 30-40%, that means the contractibility is okay. The heart pumping is okay. It gives me some idea about the systolic function. Then how well the heart is filled up gives me idea about the volume. And I can have a lot of structural information about the heart as well. Now, if I compare the other image here, this is the LV. Look at the pumping of this left ventricle and look at the pumping of this ventricle. Okay. So it's barely pumping. Okay. This one also, if you see, the circle is barely becoming smaller. It's still a large circle. So eyeballing can give you a fair degree of idea on functional echo about volume, about systolic function, and about a lot of other informations. But this is something which, even if you don't know all of functional echo, but if you just put the probe, you can see the heart and you can get some idea. I knew this is going to happen. Just give me some time. I will have to uh, close this and restart. This happens with some of the videos. So Akash has also finished up his OPD and he has joined, so that's nice to have him. Okay, so this is where we were. And then you can look at how well the left ventricle is pumping, and there are parameters to understand the contractibility of the left ventricle, how well it is pumping. So there are some terms like fractional shortening. You must have heard about ejection fraction. So we know how well it is pumping out, and we can calculate this. So we look at the left ventricular end diastolic diameter. What is the dimension of the left ventricular end of diastole when it is relaxed? and we look at the dimension of left ventricle, the diameter in systole. Okay. So if there's a change, significant change is happening in that, that means the LV is pumping well. So if it roughly comes to one third of its original configuration, then that means the LV is pumping well. And the same thing is measured in echocardiography as shortening fraction. So roughly the values around 30% are fine. There are again ways in nomograms to understand this, which I'm not detailing today, just for the benefit of the audience. Similarly, for the right ventricular function, you cannot take the EF or shortening fraction because of some limitation. So there's a parameter called tricuspid valve annular plane systolic excursion, where you can measure what is the distance traveled by the tricuspid valve to the right ventricular apex to understand how well the RV is contracting. So you can understand what is the RV function, very simple parameter. Then you must have heard about ductors and PDA, where you can make a ductal view, look at the PDA, measure it at the smallest portion in the 2D view to see whether a patent ductus arteriosus is present, number one. Number two, whether it is hemodynamically significant on functional echo, leading to shock, the presentation which your baby is having. And there are various parameters, again, based on increase in the pulmonary flow, and then again in the on systemic steel, which you need to assess before really calling a PDA significant, rather than just jumping on and just seeing a PDA. So don't just close the PDA, just seeing it. Okay. My God. So sorry. Then same way, apart from PDA, in a term baby, you can look if there's features of hypoxemia and features then leading to shock, then you should also look at parameters of pulmonary hypertension. And some of the parameters which you can look into is one is tricuspid regurgitation is one parameters which most people look into. Then you can look into the septum, how the septum is there. So normally this is the left side, this is the right side, and this is the, I hope it doesn't stop here. Okay. So I'm just trying not to play those videos. So you can look into pulmonary hypertension, and all the videos are having problem today. So sorry. You can look into pulmonary hypertension, and you can also look into the septal position. You can look into tricuspid regurgitation. There are ways to measure pulmonary artery pressure, which you can also measure, and you can know whether your child is having pulmonary hypertension, and that is the cause of shock. So sorry. Okay, so let's quickly get out of echo. It is causing more problem than helping us, right? So let's get out of this and let's go out of this. Okay. So now, as you understand that I showed you some of the slides of echo, there's a lot of problem with functional echo. Although we have been teaching functional echo, it's been like almost 2 decades now, but they have their own problems. They come with their own set of problems, and it is not something which you should swear by. Okay? It is just an additional tool for you to manage shock if you know how to use it in the correct way. So all these outputs, left ventricular output, right ventricular output, SVC flow, they can have their own limitations. LV output, RV output, they can be affected by shunts in the body, and the correlation with MRI and all those is not that great. And again, the studies they show a variable kind of findings of these outputs. Similarly, SVC flow, superior vena cava flow, which was taken as a gold standard, itself has a lot of limitations. If you measure SVC flow, you will understand how difficult it is to measure the diameter of the SVC and the VTI, the velocity time integral, in babies who are breathing spontaneously, who are not sedated. There's so much of variation which can occur in the SVC flow. And what was once thought to be a gold standard does not actually uh, meet those criterias on MRI. So there's a lot of variation in SVC flow measured in echo and measured in cardiac MRI. Then IVC indices, again, the data is less in newborn, but in adults and pediatric, it has a fair degree of predictability, good area of under of curve of zero point 0.8 to zero point 0.9. Shortening fraction, again, is a good tool to look at the contractibility, but in the first 24 hours, shortening fraction in babies, in term babies and preterm babies, may be normally as low as less than 23-22%. So that is one thing which you should understand. Plus, it has other limitations of being affected by afterload, and you only measure at a particular point. Now, we were very excited about functional echo when it first came to our hospital in somewhere in 2010s and 11s, and we learned it. And after 5-6 years, we thought, okay, let's do it in shock. And this is one study which we did in a patient who had shock. We did the echocardiography, and we took some controls. This shock was defined clinically. And then we started doing the echoes every like 15 minutes when the inotropes were escalated. So echo at shock, echo after 15 minutes of shock with dopamine, echo after 30 minutes of shock with dobutamine, echo after 1 hour of shock with adrenaline, and so on. So multiple readings we used to do, stand there at the bedside, 4 a.m., 5 a.m. And we were so excited that this is going to change the way people look into shock. But God has had some other plans. We did not find much of difference in parameters of echocardiography in shock and in controls. So all these parameters, the outputs, the shortening fractions, RV outputs, the LV MPIs, they did not show much of difference in shock versus in control. And what we found, there was some change in the IVRT, which was significant. It is shorter in shock. That could be because of increase in the heart rate, and some values in distensibility index was higher in shock, which told us that the patient who are in shock need in more volume. Apart from this, we did not find any significant parameters which was changing in echocardiography versus in echocardiography in control versus those who are in shock. And even after anotropes, we did not find much of a difference. So the kind of excitement which we had, the kind of obsession which we had with echocardiography, when you do it yourself instead of reading some other's paper, it sometimes leads you to the truth for yourself. And we published this in European Journal of Pediatrics. Many of the people were not happy with our publication because it changed the way people look into echo as a kind of Brahmastra for shock. And we are looking into some other parameters as well right now, some tissue Dopplers we are doing, but this is one thing which I wanted to share with you. Overall, I am a great fan of Modi ji, and you need to understand that you have to take the parameters in total. You have to take the parameters in an inclusive way. So, sabka saath, sabka vikas. And you take things in combination rather than swearing by or taking one thing at a time. So, you look into the various demographic parameters, and you look into the history, look into the gestational age, postnatal age, birth weight, gender, risk factors that we just talked about. Do your classical clinical evaluation. Extremely important, whether it is heart rate, whether it is CRT, whether it is blood pressure, whether it is color, whether it is perfusion index, whether it is urine output, central peripheral difference. They can itself give lot of information. And if you have some advanced tools, nobody is stopping you from going for that, whether it is echocardiography, whether it is NIRS, whether it is pleth variability index, electrometry, you take that also account. And you need to evaluate these patients based on your suspicion. So at least do a ABG, make sure you rule out sepsis in patients who crash down. So all these things, they come together when you talk about shock. And these assessment cannot take a century. You have to do these quickly, swiftly, and correctly to reach at a decision whether your baby is having shock or not and whether you need to treat. So one definition which I find practical, this was published 20 years back. Again, long time has passed, but some old people like me, they like to stick to this parameters. So if there is already hypotension defined by your normograms, your charts, and there's need for some vasoactive drug or volume 2 maintain the normal blood pressure, or if there is two of the following, whether it is unexplained metabolic acidosis, base deficit more than 5, increased lactate more than 2 times of limit, oliguria, prolonged capillary time, or increased core to periphery temperature gap more than 3 degrees centigrade. So if more than these two are present, then you should seriously think of that your newborn is in shock, and you may consider treating it based on whatever clinical history you have. So this could be a simple bedside way to define and maybe start your management, short of the various fancy things which people have. Maybe simple things can be used. Now, once you understand what is shock, and then the next thing comes about understanding the inotropes. And you have so many of the inotropes in your armamentarium, and you need to use the right one, right inotrope for the right patient. So for that, you need to understand what inotrope acts in which particular fashion. So, for example, if you look at this particular curve, this is for vasoconstriction. These are the drugs which cause more vasoconstriction. This is for vasodilatation. These are the drugs which cause more vasodilation. This is the scale. And higher you go, it is about the contractibility. So if you take some of the common drugs like vasopressin, now vasopressin is something which we use a lot in our unit. This is not an inotrope. This is a vasopressor because it does not act on the heart. It acts only on the peripheral vasculature. So it's not an inotrope. Okay. So it will lead to increase in the vascular tone, improve your blood pressure. There is no inotropy with vasopressin. Whereas norepinephrine is a weaker inotrope. It does cause some inotropy. Epinephrine is a more stronger inotrope, and dopamine also is a fair degree of inotropy. All these three drugs also have a vasoconstriction or a vasopressor effect. Then if you talk about drugs like dopamine and milrinol, they have an inotropic effect and they are vasodilator. So milrinol is the classical, what we call an inodilator, but dopamine also leads to increase contractibility and increase in the vasodilatation. Now, dopamine in a small dose, can also lead to vasodilatation because if the beta receptors of the blood vessels, if they are affected. So you need to understand how the inotropes act on and their actions on contractibility, vascular tone. This is also important. Now, another thing which I want you to understand in your management of shock is the fall in the blood pressure. So, what pressure is more effective? Is it the diastolic blood pressure? Is it the systolic blood pressure? Is both of them affected? That can give you a clue to understand what is happening to the physiology in the heart. And if you add this to the history, it can be a great help to you, even if you don't have functional echo and all those kinds of tools. So if the diastolic blood pressure is falling, it means either that the afterload is decreased, so which can happen in decreased systemic vascular resistance. This can happen in large AV shunts like PDA, AV malformations, or in warm shock, septic shock, NECSRS. All this can lead to decrease in the afterload, and it can lead to show as a decreased diastolic blood pressure. So if this is the physiology, then your management becomes a bit different. Here you are going to increase the systemic vascular resistance. So you need to use vasopressors primarily, whether it is dopamine, vasopressin, norepinephrine. If there is hypovolemia, then you need to give additional volume. If there is a baby who has a duct that is causing a problem and there's no other problem, then you may consider closing the duct. If there's decrease in the preload, that means the volume is affected, or there are conditions which is leading to decrease filling in the heart, like a pneumothorax or cardiac tempo. So in this situation, you manage these conditions. So if volume is a problem, you need to give volume. Okay. And despite correcting volume, if still you feel that the perfusion is compromised, you will need to add some pressures again. Then if the problem is a tamponade, you treat that tamponade. Now, if the systolic blood pressure is only affected, then it could be either contractibility or it could be increase in the afterload. So if the contractibility is low, you need to give some drugs to increase the contractibility, or in other causes, you try to treat the cause. So increase contractibility with those drugs which have primarily inotropic effect. So whether it is dobutamine, whether it is epinephrine, and if there is also increase in the afterload plus decrease in the contractibility, think about milrinone. Then you may need to treat the cause, like if there is PPHN, you may think about inhaled nitric oxide. If there's adrenaline insufficient, think about steroids and so on. Similarly, if the afterload is increased because of increase in the SVR, you need to give a vasodilator to help to maintain the perfusion in the body, like a dobutamine, like milrinone. Okay. Even epinephrine in low dose will act as an anatropy and as a vasodilator. And if both of them are compromised, which is what situation you and me are facing day in and day out, we are totally screwed. We don't know what drug to start with. We don't get patients in these phases. Whether we get more patients in these phases, when the PPHN is sent to you, it is unresponsive. When you have septic shock, which is progress into multi-organ dysfunction, a pneumothorax or tamponade, which has not been drained for a long time, or a duct which is already into cardiac failure, or severe hypovolemia untreated, or adrenal corticoinsufficiency, which has not been treated for days. So we get patients who have this kind of scenario where the systolic blood pressure is low, diastolic blood pressure is low, and you need to again titrate a lot of things here. So you need to think about an inotrope, which will help your heart to push and pump. You should think about uh, if the afterload is high, patient is very cold, you may think about adding something to decrease the systemic vascular resistance. If it is a warm shock, then you may uh, use a pressor as well. If there is PPHN, you treat accordingly. So all this will vary depending on what condition you have. The message which I want to give you in this slide is, unfortunately, I cannot give you one fit inotrope for all these patients. So there will be situations based on physiology where you will have to choose your inotrope or your vasopressor, whatever it is, based on the history, based on the physiology which is happening in the body. You have to understand that. Otherwise, there is no step formula of treating shock, which was done 5 years back, even in my unit. My bosses taught me that you treat shock in a very simple way. Start with dopamine, 10 mics, 15 mics, 20 mics, go 5 mics. You go ahead every 15 minutes, not responding. Then you add on dobutamine, 5 mics, 10 mics, go to 20, not responding. Then you go to adrenaline, start point 0.05, go on, so on. So that was the way I was taught. It's a very simple protocol I was taught when I was a DMB fellow doing my neonatology. But that is not the way to go about shock. That is not the way to crank up the inotrope. It's not going to help you. That's no single way formula. So, looking into the inotropy, we have already talked about the action of dobutamine, dopamine, epinephrine. I will not go into more details. So, these are some of the doses, standard doses which are used. Dopamine becomes suppressor at a higher dose. We know in adults and in pediatrics. Even in a lower dose, it could be a pressor because what happens, the alpha receptors are higher in premature babies than the beta, and it can lead to more of a pressor effect than just anotropy. So these are the doses of dopamine, dobutamine, and epinephrine, which are used in clinical practice. Now, if I take you quickly through how they have been used and studied, which is a better anotrope, one slide for each. So if you look into dopamine and dobutamine, there is less treatment failure with dopamine and higher reversal of shock. Dopamine leads to a higher increase in blood pressure than dobutamine, but dobutamine increases the blood flow, the organ perfusion more, being a peripheral vasodilator and an inotrope. So depending on what is your blood pressure, what is your problem, you have to choose between the two. Now, the recent controversy which we have is dopamine versus epinephrine. And most of us who are pediatricians doing pediatric intensive care as well, you must have already moved to epinephrine and norepinephrine as the first line drug to manage septic shock. But in neonates, we are still debating which is better, dopamine or epinephrine. And if you look at all these randomized controlled trials which have been published, so those who have included only neonates, especially premature neonates, do not show any difference in reversal of shock in mortality, whether you use dopamine or epinephrine. Two studies which score a bit higher for epinephrine, more in benefit of epinephrine in terms of improvement in survival, are they include pediatric population as well, and they show faster resolution of shock, lesser mortality with epinephrine, better organ function with epinephrine. But of course, there's risk of hyperglycemia and lactic acidosis with epinephrine. But those studies which have purely premature newborns, right now the verdict is not clear. Apart from these studies, I think one more study was recently published, which was from Rishikesh by Dr. Siprana Vasu, 2025. That also did not show any difference. And the systematic review, right now, whatever is published, does not show any difference whether you use dopamine or epinephrine as first line in shock. Then vasopressin is something which I was quite obsessed about again because we started using this somewhere around 2010. And you're excited when you are amongst the first who are using a medication. And Anita must be here. She must be remembering that we procured vasopressin from the cardiac unit because it was not available. So we were taught dopamine, dobutamine, epinephrine, norepinephrine, and then stop. There's nothing else. So we started using vasopressin. And the patients in whom we used to use vasopressin, it was where he was not responding to anything else. So a kind of rescue drugs. And whatever evidence we have, all of them are from retrospective study, only one RCT, 20 babies. So if you look into all these studies, small studies, 20 babies, 22 babies, 60 babies, what they say that vasopressin has a favorable profile. It increases the systolic blood pressure, diastolic blood pressure, increases urine output, increases in organ function. It also improves pulmonary compliance because of increased pulmonary flow and leads to decreased surfactant. These are the findings from these retrospective studies. They improves the blood gas and so on. And if you see the mortality in all these studies are high, close to 50%, 60%, because in all these studies, again, vasopressin was used as a rescue drug. So think that the survival is 50-60%, and these babies would have not survived otherwise if vasopressin was not being used. Whatever systematic review which we have, it also looks into all these studies, and I told you there's only one RCT. So it says that it leads to improves in the blood pressure, perfusion, and the problem with vasopressin is it has some side effects. You have to titrate the dose carefully. Hyponatremia is a problem, and we have kids who require very high sodium to manage the sodium levels. And again, this is a data which we published from 2016 to May 21. I told you we started using in 2010, but from we could not get those files. Those files were shredded by the administration because right now we need only files to be kept for 5 years in the unit. So we had 5 years data of our experience about vasopressin infusion in refractory shock. And we also had a similar kind of observation that it increases the mean blood pressure, systolic blood pressure, diastolic pressure, urine output. All those things are improved with use of vasopressin, even as a rescue drug. And even in our center, we had close to 60% survival. 40% of them were either transferred or died. So I take transferred as died only because the state they were transferred was not good. And it's a fair drug as a rescue at least. And I would say most of the units have now started, including ours since last 3-4 years. Vasopressin is the first line drug in pulmonary hypertension, along with a low dose of epinephrine. So that's how favorite it has become. Noradrenaline, which is again a favorite of a pediatrician. This is the favorite drug of Dr. Amit Upadhyay. He keeps telling about noradrenaline to everyone. So again, data is mainly retrospective data where it has found to be a useful drug, similar kind of profile as vasopressin, increase in blood pressure, systemic blood pressure, diastolic blood pressure, decrease OI, decrease lactate, improvement in perfusion. Apart from it, the vasopressor, it also had some inotropic effect. It has got a favorable profile in pulmonary hypertension also. So again, if you know how to use the drug, it's a good drug. Uh, One RCT was, I think, recently published, norepinephrine versus dopamine, where again, there was not much of a difference from India. But now we have more Indian units looking into these and publishing this data. So that's a welcome grace. So two of them, one from RML Hospital, Dr. Aarti Maria and Tapas published in 2025, dopamine versus norepinephrine In fluid refractory septic shock, did not find much of a difference in the primary outcome. There was something they tried to brew as an exploratory outcome that was not really great. And another again from Dr. Basu and Suprema Basu and Poonam Singh and Mayank from Rishikesh, where they look into the RCT, norepinephrine versus dopamine. Small study. Again, the shock profile was different, shock causes were different. There were some limitations of the study, but these are the two recent papers, two RCTs published from India, which as Indian, we should be aware and we should be happy our colleagues are publishing these RCTs much ahead than other people across the world, looking into dopamine versus norepinephrine as a choice of anotrope early. Milrinone again for as a limited use. It is used not in septic shock much because we face patients who have both low systolic blood pressure, diastolic blood pressure, and we don't want the blood pressure to further fall down. Some place where it has a role is a low cardiac output state. So low cardiac output state after PDA ligation, it has been found to be a good drug, even in terms of lowering down the mortality, because that is the time when the child needs a true anodilator where the afterload should be less and heart should be pumping more. For other aspects like for prevention of low systemic blood flow, again, this was the times when SBC flow was given a lot of importance, so it did not show much of a difference. Then after as a preventive therapy, it is not much of a use. In PPHN, where the blood pressure is maintained, you can use Milrinone in those situations where you're not having trouble in managing the blood pressure. Steroids or hydrocortisone, again, is, I would say, a very important drug, if I don't call it a wonder drug. It has several mechanisms to act. It upregulates the various receptors, the adrenergic receptors, the angiotensin 2 receptors. It upregulates glucocorticoids, glucocorticoid receptors, increase the ability of calcium, which helps in contractibility. So, decreases the catabolism of various kind of catecholamines. So, it has got multiple ways by which it can help you in shock. And one of the indications which is well known is a premature baby, where we suspect transient adrenal insufficiency of prematurity, where it should be given. And there are again very little data or trials if you talk about. So the oldest RCT on is published in Pediatrics 2006. And what people have found that if you use hypocortisone, it decreases your needs for anotrope. You're able to wean off anotrope earlier. The dose of anotrope is less. The need for vasopressor is less. So this is something which we are very fond of using in our unit. The controversy now is to use it early rather than late. So definitely when you're on two anatropes, you should think about using hydrocortisone and instead of waiting for three anatropes to use hydrocortisone. This is a drug infusion, the way we use it in our unit of various drugs, adrenaline, dopamine, dobutamine. This is a handout again, which is given to all the residents, all the nurses. It is kept in the SOP book so that everyone uses the anotrope in the same way. So the maximum dose of adrenaline which we use is again very high, almost 1 mics per kg per minute. And this is the way we prepare it. If you want to use it, you can take a snapshot and use this chart as well. Echo I have already talked about. I will skip for the time, and I'll try to now combine this maybe next two slides and try to finish up in next 5-7 minutes. So, yeah, someone wants to speak something? Okay. So if there is a, how do you combine what you learn from functional echo? So if there is a clinical scenario of hypovolemia, or already there is history of blood loss, then suppose there's history of sepsis, NEC, there's capillary leak you are suspecting, these features are there, then you will, yeah, sorry, Priyanka, you say something?
No, sir.
Okay, okay. Okay. So if there are this kind of situations, then these are your functional echo cues. So whether functional echo or no functional echo, you will end up managing these situations with a fluid volume boluses. Functional echo can give you additional indices, like you will see the IVC indices, they will vary, the cardiac output is low apart from variation in the volume indices. Now in transitional circulation in newborn babies, what is happening? The myocardial contractibility is compromised. The blood pressure might be normal because of increased SPR. So if you find a baby who has a poor perfusion, but the blood pressure is maintained first 24, 48 hours, then you think about starting dobutamine. Here the blood pressure is maintained and your job is to increase the organ flow. On functional echo, what you will find? You will find low SVC flow, impaired contractibility, low SF, or low LV out. Now in PPHN, what you will have? You will have history of most cases. You will have history of hypoxemia, meconium, asphyxia, pneumonia, which was there already, and there could be secondary PPHN or history of drug intake in the mother, or sometimes there could be a primary pulmonary hypertension. So you will have different echo findings, and if there is hypoxemia, you think about using a pulmonary vasodilator, which will be inhaled nitric oxide if you have. Short of that, you can use sildenafil and bosentan, whatever you have. Blood pressure is normal, you can think about using milrinone. If there's a low blood pressure, low cardiac output state, there is already a cardiac dysfunction which has set in, then in those situations, you should not use vasopressin alone, because here there is cardiac dysfunction. With vasopressin, you will increase the afterload exponentially and your patient will crash down. So here the drug of choice would be to start first the baby on epinephrine, and then once you restore the cardiac function, you may add on vasopressin. Okay. Low blood pressure, normal cardiac function. Again, uncommon scenario for us Indians. So here, if you have this kind of scenario, you can choose vasopressin. So see, most of the drug which you're choosing is based on history and physiology. Sepsis and NEC, again, if there is a warm shock will be there. There will be vasodilatation and there will be low diastolic blood pressure. This is a high cardiac output state. Here you will need a pressor, which can increase the vascular tone. So you can use again vasopressin or dopamine as a first line. But if the cardiac output also is low, then you can add on dopamine or epinephrine. If there is cold shock, where there is low systolic blood pressure, it's a low cardiac output state, then you can choose epinephrine. You can start with a low dose epinephrine. Now, large HSPDA leading to systemic steal will again lead to low diastolic blood pressure first. So drug of choice remains dobutamine here. Later on, what happens if you leave it untreated? Further, what happens? The LV preload is increased. There's low systolic blood pressure as well. So this can happen in PDA. The drug which we prefer to use in PDA as a first line is dobutamine, because that helps to increase the contractibility of the heart, and that will also decrease the shunting of from the PDA to the pulmonary circulation. Following ligation of PDA, when there is a cardiac output is compromised, it's a low cardiac output state. So we want to help the heart to pump and we want to decrease the vascular tone. In these situations, you should use again dobutamine or milrinone. These are good drugs. And you will see them happening usually after 6-8 hours of after ligation, when the LV starts to get tired of pumping and starts to get compromised. Now, when there is a hypertrophic cardiomyopathy, you may see it as a diastolic dysfunction. The filling is compromised of the heart. Here, you should not be giving ionotropes. It is contraindicated because that will further compromise the organ perfusion and the cardiac output. You can add on beta blockers to this patient if it's significant. And if there is shock, then you use pure vasopressors in this condition, not ionotropes. So this is the guideline which you will see for shock, published by American College of Critical Medicine. And this guideline has not changed, although Surviving Sepsis Campaign 2025 has been already published for pediatric shock. It doesn't talk much about newborn shock. And these guidelines are rather simplified for everyone. But if you see, if there are signs of shock, you manage the airway to maintain the airway. Most of our patients will get intubated. Establishing access, you may use your cannula initially, but try to get a central venous access. You may start with a small volume initially. Be cautious in a preterm baby. You give small volumes, only 10 ml per kg over 30 minutes. You correct the other issues like hypoglycemia, hypocalcemia if they are present. Whenever you suspect septic shock, start empirical antibiotics, and we are very good in starting antibiotics. But whatever studies have shown that if you start antibiotics within 1 hour in septic shock, it cut down the mortality significantly. So this is a good practice if you're not sure what is happening to your baby. Now, in conditions where you're suspecting a duct-dependent lesions, you may consider prostaglandin. This is especially true when you're not suspecting a septic shock. This is when you're suspecting more a cardiac shock, a term baby. Shock is not reverse, it's a fluid refractory shock. You quickly move to your anatropes. What you want to choose, again, is quite varied. As neurologists, most of us are still sticking with dopamine in septic shock, and then you add on epinephrine or dobutamine. And this is an area which is quickly going to be solved in the next 5 years. I hope in my lifetime, if we have larger sample size, babies with large studies with larger sample size. Then if it is not reversed, it is a fluid refractory dopamine resistant shock. You think about hydrocortisone. So you see here, hydrocortisone is coming much low down the order. This is not something which we are practicing. We push hydrocon much up the order compared to waiting for three anatropes to come down. Then, depending on what is the situation, you may need to further add on your drug. So, if it is a kind of cold shock, normal blood pressure, evidence of poor LV function, that means you need to do echocardiography. So, you add milrinone. You have a cold shock and the RV dysfunction. RV functions are basically compromised. And if there's PPHN, you add inhaled nitric oxide and milrinone. And warm shock with low blood pressure, when there is vasodilatation, you consider a vasopressin or pressor. If shock is still not reverse, you make sure you think about, you've already thought about, I suppose, of the tamponade situations like effusion, pneumothorax. Okay, and if there's a PD, think about closing and so on. And last is to consider ECMO, which again in premature baby is very, very, very difficult to get the right cannula. And we don't do ECMOs in our setup in babies who are less than 2.5 kgs and babies who are less than 34 weeks. There are some units which also do premature ECMOs in the West. We are still very scary and we have just started it maybe just 7, 8 years back. So we are still learning. That could be a tool. This is a picture of a baby who had hypoxemia, who came to us with shock. The saturations were fine. The hypoxemia was okay. He was on 21% FiO2 on high frequency ventilator. But we were not able to manage the perfusion of the baby. He was already on dopamine, dobutamine, epinephrine, vasopressin, and all those. And when we call the cardiac people, they first scolded us that why do you put so many anatropes? You don't know what is happening. You play with so many high anatropes. Your anotrope score is 500 or 400. But that is the way we neonatologists manage shock. We use a lot of anatropes and we use it on high doses. So, but this space perfusion was still seesaw kind of perfusion, blood pressure was swinging, not good. So we ended up doing ECMO for this baby, a term baby, and this baby is currently in the NICU. We are weaning the baby with currently on high frequency and nitric oxide still, but hopefully he will come out now. He's looking quite okay to me and should be able to come out. So the key messages to you is one that do not get rid of the clinical criteria to diagnose shock. They still have a good degree of accuracy in combination of fair degree of accuracy close, predictive value close to zero point 0.9. So make sure you take the clinical history and the clinical picture together and you decide what is happening in the body. You please understand that there is no single cut protocol which I can give you. Functional echo, if you have, you're most welcome. Please use it. Please use it. But use it in the right perspective. Don't get overboard, obsessed with technology. We have burnt our fingers. We have learned it the hard way. Over whatever I'm telling you is over last 20 years of experience and some bit of research that we have that I'm telling you. Use it as an additional tool. Don't jump. Don't swear by it. You can be wrong. Next is talking about the first line anotrope in septic shock, dopamine versus epinephrine. Right now, at this point of time, I don't have insufficient evidence to recommend epinephrine over dopamine. Dopamine has been used for ages now in neutral septic shock. People are more experienced, more comfortable, and they still tend to use dopamine as a first line agent in septic shock in newborn babies. In PPHN, people are shifting gradually to vasopressin and epinephrine as they understand the pathophysiology better. Compared to dopamine and dobutamine, dopamine increases the blood pressure, dobutamine increases the organ flow. That's the basic thing which you need to understand. Vasopressin and noradrenaline, again, lot of data, all small studies, mainly retrospective. Only last 2, 3 years, randomized controlled trials have started to come. They're also mainly from India. So if you can club and join, if many centers can do some good RCT, it can be practice changing. And one as Indians and being in Uttar Pradesh, one of the largest state, I mean, which you stay largest number of NICUs and so many neonatologists, so many researchers. You have Dr. Amit, you have Dr. Akash Pandita, who are the pundits of research. You think about doing a large RCTs, trying to resolve these issues. Then milrinone, okay, the use is limited in septic shock, but for low cardiac output state, PPHN, you may think about using it. Hydrocortisone, again, try to use it early when you are on two inotrope rather than waiting for the patient to deteriorate. There's no use of sending cortisol sample and waiting for it. That practice is not there. And always focus on treating the cause, whether it is supraventricular tachycardia, whether there is a duct dependent, it's a systemic lesson, whether it is pneumothorax, tamponade, sepsis, you have to treat the cause to hit shock ultimately. So if it is an SVT, there's no point giving inotropes. You have to treat the SVT first. Okay? Now, choosing inotropes, again, I cannot give you a single kind of formula like my boss made it simple for me. I can't make it simple for you. So please forgive me for that. You have to depend on what is the clinical setting. You have to understand what is happening in the body, you have to understand the physiology, what is happening to the various parameters. And then, based on your history, your clinical examination, understanding your physiology, you choose the right inotrope. And there's no harm if you're functional echo, you can use it. If you available, you're trained to use it in the right perspective. Don't go overboard. Okay. So still at the end, I'm sure that you are still like this five blind men, not knowing how to treat shock in the right way. But that is how I intended to leave you also. And the last message, which most of you must be aware, is one is that you should not get totally fancied with technology and keep using your clinical sense, your clinical acumen. We all are clinicians at the end of the day, and we need to understand that that is not going to go. You can use technology, you can use all the fancy measurements, you can use artificial intelligence. Please use, go ahead, use them in the correct way, and but it will not take off the clinical acumen completely. So thank you so much. It's already more than an hour, 10 minutes I took. So if you have any questions, which I'll try to answer them if you have any of them. Thank you, Priyanka. Thank you, Dr. Amit.
Thank you, sir. That was a wonderful and very extensive talk, sir. That was a really very good talk. Over to you, Amit, sir. Amit, sir, would you like to take up the questions?
I was mute. I'm sorry. So let's take up the questions, and one is from Dr. Gayatri Ramesh. And Dr. Gayatri says in a 32-weeker with severe post asphyxia, PPHN, myocardial dysfunction, refractory shock despite maximal dose epinephrine. What is your next management strategy? Yes, Doctor. Dr. Anup.
Yeah. So let me first understand. So it's a 32-weeker with severe pulmonary hypertension. And I guess the pulmonary hypertension has been diagnosed in echocardiography. That's number one. Number two, uh, if you suspect pulmonary hypertension in a 32-weeker baby, I am sure you must have already given push through surfactant to make sure the lung is okay. Number three, you look for if there's a history
Severe
of
birth
or
asphyxia as well.
yeah, severe perspective as well. Yes, and you also look whether there is any history of oligoamnias was there because those are the infants where there is antepartum history of oligohydramnios, this history of leaking. They are more prone to have pulmonary hypertension. So look into those factors. Now, if you have already started epinephrine and there is refractory shock, now I would love to start nitric oxide if it is available there. Although the recommendations for preterm baby are still stringent, but most of neonatologists would start in the scenario of pulmonary hypertension, severe PH, people would like to start nitric oxide. Short of nitric oxide, which I understand which can be there in your unit, if I'm faced with these scenarios and if I feel the cardiac function is getting better, I would love to add a low dose of vasopressin in this scenario, because vasopressin is a drug which will increase your vascular tone in the systemic vessels, but it will cause pulmonary vasodilatation. It will help your lung compliance to get better. It will help your pulmonary pressures to come down. It will maintain your systemic blood pressure. It will maintain your brain perfusion. It will maintain your coronary perfusion. So that would be my approach if it's this kind of scenario.
Steroid would come into picture as well. Some
Steroid,
states.
so sir, as steroid, I assume it's already there. When she's telling that maximum dose of epinephrine, steroid has to be there. Two inotrope, go for steroid. Max dose of epinephrine, go for steroid. No doubt. Hydrocortisone is much, much up.
Yeah, so we would have needed some more information. Why did we go to maximum dose of epinephrine? Was it low blood pressure? Was it how high are the lactates? And so many, as Dr. Akash was saying, that clinical acumen is important. So for clinical acumen, first is all the resources have to be there. There is no fun in having inotropic support and fancy ventilators if we are not monitoring urine output. Many times the babies are not catheterized, and in a very critical babies, you can just can't be weighing nappies to have the urine output monitoring. Appropriate side BP cuffs, they have to be there, and frequent X-ray facility, frequent ultrasound facilities, and if we are to manage such critical babies, then some trained nurses who are there all the time, who can be there bedside, your fellows who can be there bedside, they are equally important as the echo machine, as the nitric oxide, because delay in a couple of minutes in diagnosing a rapidly progressing baby can, we have already missed the bus. So if your blood pressures are coming down, if perfusion is going down, then early identification is the key. So you have to be on the toes, on your toes all the time. The communication has to be very swift, and orders which are there have to be carried out immediately. At times, somebody says do this, and that being done on the baby takes, if it takes 30 minutes, then there is no fun in managing such babies. So, uh, you know, the ground realities could be very different from what we are talking on webinar, and those ground realities have to be looked at, and minimize the time between baby falling sick to somebody seeing the baby, to somebody ordering what has to be done, to that being implemented on that baby, and then you see the effect of that implementation on the baby, and then you have the next strategy which is there. So it is something which cannot be done on phone while you are at your home or in your OPD. You need to have some intensivist at the bedside doing all the stuff for that baby to be managed properly. What do you say, Dr. Anup?
Yeah, I think it's quite right. And one is the limitation of technology, which I understand. Technology will be not be the same. We are a country where there's a lot of diversity, which I agree. One thing which we can improve is our knowledge and our training. So that is something which we as clinicians, as pediatricians, as even nurses, we should try to increase our training, our observation to diagnose shock quickly. It should not be a late diagnosis. If it is late, then you are missing the bus. If you're picking up a baby on a pH of 6.7, 6.9, then it's almost like missing the bus, as you rightly said. Third is, of course, you have to understand your limitation, right? Like Dr. Amit emphasized that there is a phase when you need to say that, okay, I will stop here and I need to refer this patient in the right way to a higher unit, which could be anything nearby. But that stoppage should not be in a state where you have led to a state when the baby could not be saved. You are just sending the baby to another unit to be declared. So the stoppage should be to give a fair enough cushion to your colleague to save the baby. So if your baby is hypoxemic and having pulmonary hypertension, there's no point waiting to keep the baby on high frequency ventilator 100% FiO2, then keeping the baby on HF 100%, and then not giving nitric oxide. That is not acceptable in today's world. So if you see the baby's hypoxemia is worsening despite your inotrope and high frequency ventilator, is 40%, 50%, whatever, give some margin to your colleague to save the baby so that he can start nitric oxide. Similarly, if you have a nitric oxide and you don't have ECMO and there's a term baby, and there are parents who could, some of them could afford the treatment. Thankfully, we don't have ECMO in all government institutes right now, and healthcare is not that great. But it should be offered to the parents. If you're not offering to the parents and not referring them in the right way, then you could be sometimes caught in a soup. And again, here also you need to give some cushion to the unit where you're referring. We get referrals for ECMO when baby's pH is 6.7, 6.8, baby is bleeding from everywhere, then DIC. We can't do ECMO also then. So then there's no point. It's just like sending us to write a death certificate. So give some cushion to your colleague, pick up shock early. That's one. Refer them at the appropriate time. I'm not saying you refer all patients. No, you are also pediatricians, neonatologists, but refer them at some point of time to give some cushion to save the baby. Transport them in a right way. You can just don't brush them off. They should be going on a ventilator. They should be going on an inotrope. Warm should be maintained. Otherwise, there's no point. I mean, you can't save this baby. So that point is very rightly made by Dr. Amit. I'm not against lack of technology, but understanding limitation is very important of every unit, whether it is mine or your, and upgrading your knowledge, upgrading your skill, knowing simple thing, blood pressure. I don't know how many units in India are measuring blood pressure. If you do a survey in the right way, what cuff size should be used, how much it should cover for the circumference, method used. These are very important messages which Dr. Amit gave in a very simple way. Uh, Blood pressure measurement, urine output measurement. Forget about NIRS PI. That is okay. But what about these things? Are we doing this correctly? No, I don't think so. So these things need to be streamlined first before jumping to more fancy and sophisticated things, actually. Amit sir, are there any more questions? Or
I think no more questions. And
okay.
Dr. Akash.
I think excellent session as always, and very complex topic made simple, and very valid points at the end. I think that should be the take home message for all of us. Thanks to the speaker and the moderator for making
Thank you.
an enjoyable one.
Thank you.
Thank
Thank
you
you,
very
Amit sir.
much.
Thank you, Amit
Okay,
sir.
Dr.
Thank you.
Anoop.
Thank you,
Thank you.
Akash.
Thank you for
Yes,
coming
sir.
to UP.
Okay. बुलाया कहाँ सर आपने
Thank
अभी
you,
तो?
sir.
Okay, bye
आप
bye.
बॉर्डर
Take care.
पे हो.
बॉर्डर पे ही है सर मैं तो. Okay sir. See you in Udaipur sir.
Okay,
I
good
think we
night.
will be
Bye
there.
bye.
हाँ. Okay. Bye bye.
आपको यूपी बुला रहे हैं, यूपी न्योकॉन में.